Manipulative therapy versus other therapies for chronic low back pain, the Cochrane reviews. It may seem from your experience that your chronic low back pain patients respond well, or perhaps you've noticed that managing them is more difficult than acute patients with the need for ongoing care or even referral. You may be interested then in the current overview of 2 Cochrane studies that examine that issue. This publication is a follow-up to a Cochrane review published in 2004. The authors note that there have been a number of newer randomized controlled studies, totaling around 17, that were included in this updated review. They also state, though, that the conclusions remain the same. The conclusions in a minute. This revision was published in the journal Spine in 2011. The title of the review is Spinal Manipulative Therapy for Chronic Low Back Pain, an update of a Cochrane review. Note that the primary investigator, Sidney Rubenstein, is a chiropractor. Although the general perception by chiropractors is that manipulation is now an accepted approach for low back pain based on various U.S. and Canadian guidelines or recommendations, the authors note that there is a wide variation based on the type of low back pain and the specific country listed. For example, spinal manipulative therapy is not recommended for acute low back pain in the Netherlands, Australia, and in Israel. Yet, SMT is considered a useful option for subacute and chronic low back pain in the Dutch and Danish guidelines. Why such variation? All the variables you might imagine. Which studies are included? What is the comparison for effectiveness? How much change is needed to equal success? Who are the patients? What type of manipulation? And certainly to some degree any bias on either side of the equation. The purpose of this study was to look specifically at chronic low back pain and to look at the effectiveness of spinal manipulation compared to other approaches. In other words, how much better is SMT compared to other common approaches? Let's look at the inclusion and exclusion criteria used for the studies reviewed in this study. Standard were the inclusion of studies with men and women over the age of 18, but also included were patients with or without radiating complaints, and also studies performed in primary, secondary, or tertiary care facilities. Well, let's stop here for a moment. We do have to question whether the response to care is the same for patients across such a broad age range. Also, are patients with radiating complaints going to respond the same as patients without? And are patients in tertiary centers where the assumption is they have failed standard medical care the same as those in primary care? Exclusion criteria seem reasonable, although I'm not sure how they exclude studies that evaluated response for patients with sciatica or known pathologies, but use an inclusion criteria that allows studies with patients that have radiating complaints into the lower extremity. The researchers have clearly assumed that the radiation of complaints in the inclusion group was referred pain because this was included in their definition of back pain. We must also assume that these patients did not have clinical exam or imaging confirmation of nerve root involvement. So who were the comparison groups? Let's start broadly, and then we'll specify some of the comparison interventions. There were 4 comparisons: SMT versus inert interventions, SMT versus sham SMT, SMT versus all other treatments, and SMT in addition to any intervention versus that intervention alone. Most, as you can see, involved SMT compared to other treatments. So what is SMT in this study? Spinal manipulative therapy was a broad definition in this study, allowing both thrust and non-thrust techniques and also mobilization. Some might consider this approach too inclusive, making the interventions too heterogeneous. So, who performed the SMT in these studies? The SMT was performed by chiropractors in 10 studies, while the other practitioners in the remaining 11 studies included manual or physical therapists, medical or orthomanual practitioners, a bone setter, and a napropath. So what were the comparative interventions? These included the obvious, such as massage, exercise, acupuncture, but also included physiotherapy generally, and specifically shortwave diathermy, another using ultrasound, usual medical care, including analgesics, back school, an educational booklet, and myofascial therapy. The SMT Plus intervention studies included myofascial therapy, exercise, analgesics, and usual medical care. So how was the quality of the studies evaluated determined? In addition to having a prerequisite that the study had to be a randomized controlled study, the researchers applied the standard Cochrane approach of evaluating the level of bias, called risk of bias. The evaluators for this review used a standardized evaluation tool, which then places the study in a category of a high to a low risk of bias rating. Examples of issues indicating risk of bias are primarily focused on appropriate randomization, blinding, similar patients in each group, dropout rates are low and compliance is high, and how and when outcomes are utilized among groups. It should be noted here that one problem with manipulation research is the ability to blind the patient to that intervention. Unlike a medication where you can mask the drug through packaging, manipulation is an obvious treatment in contrast to, let's say, exercise or even massage. This then tends to result in a rating of a higher risk of bias in SMT studies. It's now time to get to the results. We'll look at these in two different ways so that you'll understand what they mean. First, the numbers. The authors used a measure of the difference in effect between SMT and its comparison. In essence, the more negative the number, the better SMT is compared to the other interventions. So here we can see that for patients with chronic low back pain, pain in the short term is a negative number of negative 4.16, with the range of studies mean difference reflected in the 95% confidence interval. For short-term improvement in functional status, the number is also not impressive at a negative 0.22 and with a fairly tight confidence interval of negative 0.36 to negative 0.07. So how is all this interpreted? Statistically, there is clearly an advantage to SMT over other interventions, not due to chance. The question the authors try to address is whether this is clinically relevant, meaning would this degree of difference between SMT and other therapies be recognized as valuable to patients? They created a category of the degree of effect size as small, medium, or large, and created scales for each. Looking at the results and comparing to the scales of effect size, we see that for pain you would need at least a 10 to 20% change to get to a moderate level of effect. Here's the problem. The pain scale used was a 100-point scale, not a 10-point scale. So what may at first appear as a 41.6% difference ends up being only a 4.16% difference between pain scores. The difference in functional status is also in the small effect size category. For those of you who noticed the risk ratio listed in these categories, a point of explanation. The RR was used for dichotomous data such as return to work or recovery. Studies tended to not focus on these measures, and so therefore there is no real comparison in this review. Now let's utilize one of the most important but often ignored approaches to getting a sense of how well interventions work. This is called a forest plot. It takes advantage of a visual presentation of effect that mirrors the results of the study or studies. It gives you the forest view versus the tree view. You'll see how easy this is to interpret. Let's look at mean differences displayed on a forest plot. The indicator of no difference is 0. For interventions that are compared to, let's say, a pain scale, the lower the pain scale, the better, which is going to be reflected as a negative number when compared to the other intervention. The mean or average is reflected by the pyramid in this graphic. We see also a line that extends from the pyramid. This represents the range of results in the study. If that crosses the middle or 0 line, as the bottom pyramid lines do, you would realize that the results are inconsistent and to some degree conflicting, indicating a difference on one end of the range and no difference or the opposite effect on the other end. Stay with me. Look at the pyramid on the far left. How would you interpret that pyramid and its lines? This would be reflective of a large difference in favor of that group of patients. In this example, that would be the SMT group. Now, which pyramid do you think is reflective of the results of this review study on SMT? That's right, the top just shy of the zero line, but note that its range is still to the left of the zero line. So good news, right? Well, only statistically. We find that SMT is statistically better, but you also saw that it was not too far left of the zero line indicating no difference. This is why the authors come to the conclusion that although the difference in favor of SMT compared to other interventions is statistically significant, it's not clinically significant. Well, before we get on our soapbox and complain about how we are always treated unfairly as a profession or how flawed science is, we should celebrate. We are actually in a position to be considered on a high enough level scientifically that a group such as the Cochrane collaboration and top scientists take us seriously enough to investigate. We have reached a point in time that there are finally enough studies to review and evaluate to generate an opinion. We're not alone. All therapies, including medical therapies, are under serious scrutiny at a time when not only effectiveness, but cost are considered. It's also time to recognize that not all news is necessarily good news. We have to be able to look at neutral or inconclusive results and realize that this is simply a call for more research or perhaps balance with different types of research, not only randomized controlled studies. It may also cause us to re-examine what causes patients pain, in particular chronic pain. Let's look at some other comments made by the authors that are interesting and some quite encouraging. The authors did conduct a sensitivity analysis to determine any gross effect that the type of technique or type of provider had on the results. They conclude that there was no effect based on these variables. We need to remind ourselves that this was a comparative study attempting to see the benefit of SMT compared to other commonly used interventions. Looking at SMT alone without comparison, the authors do state that SMT or SMT plus another intervention did have a statistically significant effect. They do admit that looking at chronic low back pain as a category may not be specific enough to tease out clinical effects. In other words, this broad category likely includes subgroups of patients who may demonstrate benefit compared to other subgroups. In comparing these results to other studies, in particular the UK BEAM trial, they point out that what appears to be a trivial clinical benefit for, say, a 1.87-point change in the Rowland-Morris questionnaire, when translated into number needed to treat, is more impressive. Remember that the number needed to treat is equal to how many patients who need to be treated to result in one patient getting a benefit. They estimate that for the UK BEAM trial, a reevaluation indicated an NNT of 4 to 5, meaning for every 4 to 5 patients referred for manipulation, one patient would statistically be likely to benefit compared to usual care. This is considered quite impressive. This is a very well-conducted systematic review and analysis of spinal manipulative therapy compared to other commonly used interventions for chronic low back pain. It is clear that SMT is effective, but clinically may not be much more effective than other commonly used interventions. For patients, then, the question is one of preference and value. For that, the convenience, cost, and safety of each intervention must be determined and compared. For healthcare systems, similar questions need to be considered with the weight of that decision based on cost and cost effectiveness. Clearly, more research is needed, but realize that this review with others will be part of a trend of comparative effectiveness research, where the next step will be practical applications in real-world settings.